So we've talked a lot about the challenge of being able to get anything done in terms of health policy in the United States. So what actually exists? What is our social welfare policy and program infrastructure for addressing health needs? We're going to be focusing on 3 core federal health policies in the next little bit of this lecture. Those are Medicare and Medicaid, which were created in 1965 as an amendment to the Social Security Act. This was part of President Lyndon Johnson's Great Society and War on Poverty initiatives. In 1997, we saw the creation of the State Children's Health Insurance Program under the Clinton administration. This was created by the Balanced Budget Act, but enacted Title 21 of the Social Security Act. Finally, one that may be more on our radar because it's been discussed a lot even recently is the 2010 Patient Protection and Affordable Care Act. We'll be referring to this as the Affordable Care Act, or ACA, through the rest of this presentation. This was President Obama's one of his key legislative initiatives that increased access to health insurance for millions of Americans. First, we're going to take a minute to talk about Medicare and Medicaid. So these programs were created together in 1965, as we mentioned previously, but they're 2 separate programs. Medicare is actually a social insurance program that provides coverage for older adults age 65 and above. It also does provide some coverage for people that are younger than 65 but have certain chronic illnesses or disabilities. When we think about social insurance programs, we have to remember that these are programs that are paid into. So when you work in the United States, you will see a payroll deduction on every paycheck that you get that is going to support Medicare. This is a universal program, so at the age of 65, anyone in our country is eligible to receive Medicare services. It's of note that in 1966, 1 year after Medicare was created, 19 million people, all of them older adults, were enrolled in the program. By 2010, just under 47 million people, both older adults and individuals with disabilities, were participating in the program. On the other hand, we have Medicaid. Medicaid is a public assistance program. So this means that Medicaid provides health insurance for eligible low-income individuals and families. This is a means-tested program. So individuals and families have to demonstrate need in order to access Medicaid. Medicaid is jointly funded by the federal and state government, but administered at the state level. In 1975, about 22 million people were served by Medicaid. As of December 2017, 68 million people participated in the Medicaid program. Next, we're going to talk a little bit more in depth about the State Children's Health Insurance Program. Sometimes you'll hear this referred to as SCHIP or even just CHIP. This was the 1997 initiative that created a subsidized private health insurance program for uninsured low-income children. So parents are able to enroll their children in this program based on their needs, and their co-payment, or what they pay for health services, is based on both their family size and income. Again, like Medicaid, the SCHIP program is financed jointly by federal and state governments, but again, the benefits are administered at the state level. And this means that there can be a lot of variability in this program because states determine the eligibility requirements, the program design, the benefit package, and the payment levels for coverage. The CHIP program really helps to close a gap. So these are families and children who don't qualify for Medicaid based on their needs, but are unable to access private health insurance on their own. And as a result of this program, almost 7 million children were covered by CHIP as of December 2017. I also just want to highlight that together, children represent half of those individuals enrolled in either CHIP or Medicaid. So a large portion of those individuals in our society who are in need of or accessing government health insurance programs are children. Finally, we want to move into the third of the core health policy initiatives undertaken in the United States, and this is the Patient Protection and Affordable Care Act, or ACA. The ACA has three main components that we'll speak to in a little bit more detail as we move forward, and they consist of insurance reform, delivery system reform, and financing reform. With the insurance reform, the goal of the ACA was to really increase access to care for people living in the United States and decreasing discrimination by insurance companies. So some of the core regulations that were included in the ACA include providing coverage for individuals with pre-existing conditions. Prior to the ACA being passed, pre-existing conditions could be used as reasons to deny health insurance, and so the ban on this discrimination took effect in 2014. Insurance reforms also included expanding coverage for young adults who are on parents' plans to the age of 26, prohibiting lifetime or annual benefit caps on insurance policies, taking away co-pays for preventive care. So when you would go in for a preventive care visit, insurance plans can no longer require you to pay a copay or a fee to have that visit. The ACA also banned insurance companies from being able to cut people off when they get sick. Another piece of the insurance reform focuses on creating a consumer appeals process and improving financial transparency on the side of the insurance companies so that consumers have a better idea of what to expect in terms of their financial obligation. We also saw some substantial delivery system reforms with the ACA, the most significant of which was the creation and implementation of healthcare exchanges. So you may be familiar with the healthcare exchanges, but what happened was the government created state-based exchanges with subsidies available so that those who are uninsured or self-employed could purchase insurance. The subsidies were available for individuals and families making between 100% and 400% of the federal poverty level who were not eligible for Medicaid, Medicare, or already covered by an employer-based plan. I do want to make a note that undocumented immigrants are not eligible for these healthcare exchange plans, even if they were to be paying the entire amount out of pocket. We also saw a significant delivery system reform in Medicaid expansion. So the individuals and families eligible to receive Medicare was increased by moving the eligibility criteria to include anyone whose income was 138% of the federal poverty level or below. Also, coverage was expanded to childless adults. And again, I just want to reiterate that undocumented immigrants are not eligible for Medicaid either. What was interesting about the Medicaid expansion was it was actually challenged by states, and the case went to the Supreme Court, and the Supreme Court upheld the Medicaid expansion, and it was ruled a voluntary action by states. So not all states decided to participate in the expansion, but the states that did saw significant increases in the number of insured in their states. The ACA delivery system reform also implemented an individual mandate for obtaining health insurance coverage. This started in 2014 and means that everyone has to purchase health insurance or face a $695 annual fee. It is of note that the healthcare exchanges were meant to increase access for these folks, and some exceptions were made for low-income individuals and families so that they weren't facing the fee if they weren't able to obtain insurance coverage. There was also an employer mandate, which technically wasn't a true mandate, but stipulated that employers with more than 50 employees had to provide health insurance or pay a $2,000 per worker per year fee if any of their workers received a federal subsidy to purchase health insurance individually through the exchanges that we talked about a bit earlier. We also want to talk a little bit about the finance reform. So how did the ACA address the costs of implementing these changes to the delivery system and the insurance system? First, I want to just say that the Congressional Budget Office had predicted that the ACA would cost $940 billion over 10 years. However, this Congressional Budget Office also predicted that the changes would end up reducing the deficit by $143 billion over the first 10 years and $1.2 trillion over the second 10 years. So back to how these changes were paid for. One was to add a Medicare payroll tax on investments for high-income households. So households making over $250,000 a year would have an additional payroll tax. Also, there was a tax on what were referred to as Cadillac private insurance plans. So actually beginning this year, insurance companies are paying a 40% excise tax on these Cadillac insurance plans that are worth over $27,500 for families or $10,200 for individuals. Finally, I think this one is the most innovative. To pay for the ACA, an indoor tanning service tax was implemented, in which there's a 10% tax on all indoor tanning services, and that tax goes directly to support the implementation of the ACA. So you might be wondering, the ACA has been in place since 2010. What are we finding in terms of its impact? Well, let's look at the percent of population without health insurance. We can see a dramatic decline. So what the graph shows, you can see historically there was a huge decline with the creation of Medicare and Medicaid, and then we began to see throughout the 1980s a pretty steady increase, and another little bit of an increase between 2005 and 2010, and then a fairly striking decrease. So in terms of being able to access health insurance, in terms of individuals living in the United States and their ability to access health insurance, the ACA has certainly had an impact. We can see that the uninsured population has dramatically declined. You may also wonder about the cost of coverage. The cost is a huge concern and has been a big part of the healthcare debate. We've seen, cost increases for private insurance plans over the last, 3 to 4 decades. So we can see from this graph that the annual cost of insurance for consumers in the United States did decrease. However, premium increases are continuing and remain a concern. So you'll hear a lot of folks who don't support the ACA speaking to this point as a negative. And we really don't know what's going to continue to happen with these costs, but it's important to note that we did see a decrease, but those increases are, popping right back up again. So it's inconclusive, the cost impact in terms of, consumers' out-of-pocket expenses. Finally, one thing that's important to be mindful of is the ways in which the ACA has or has not impacted access to health insurance across race and ethnic populations in the United States. And so what we can see is that the decrease in uninsured individuals occurred across racial and ethnic groups. There are still significant disparities in access to insurance coverage across racial and ethnic groups. And so this is something that we want to be aware of and continue to have on our radar as to how we can work to advocate and support policies that will address this gap and work towards eliminating these unacceptable healthcare disparities.